You still there with me, Candace?
Sorry, I forgot to press record, so I went to go do that. And so, wait, here we go.
Let's start over.
Sorry, let me go ahead and get it.
Do you want to start over? I guess we could start over quick. Any
No,
questions?
no. I think we're good.
All right.
Okay.
Okay, I'm holding my phone.
Can we see the screen? Am I sharing?
Yeah, I see this says the meeting is being recorded by the host or participant.
Okay, and then are you not seeing that my shared screen?
Well, you've got this thing that's, let me see, maybe I have to push a button here. It looks like it's being blocked by something. Okay, maybe hold on a second. Okay, now I got it.
Okay.
And now on my phone, of course, I'm getting all kinds of text messages too.
Here, use mine.
Your computer?
Yeah. Your audio is still the phone. Okay.
Oh.
Okay. I'm in the meeting, but I'm muted.
Oh. Okay. Hopefully you guys can hear me now. So, some important things that we like to make sure our patients know is that these immunotherapies that we give to patients, they don't always work, but they also, when they do work, they can cause side effects that would be related to causing the immune system to attack the host too, which we call autoimmune disease. So some of the side effects that are related to immunotherapy are that the patient's immune system can become overactivated and attack their own body. So some questions here: why do immunotherapy treatments work so well? How can they be combined with other treatments? And in a patient's course, what is the best time to use immunotherapy, and what are the long-term side effects? So we use so many different types of immunotherapy and in so many different diseases that there's a lot of different settings that we use it in. Initially, it was in metastatic cancer. Now we're using it in what's called neoadjuvant therapy, which means before a patient ever has surgery. That's okay. Oh. We use it after a patient's had surgery, which we call adjuvant therapy. And some of the latest treatments are very exciting, like we're using it in a type of breast cancer called triple negative breast cancer, which is one of the hardest diseases to treat. And we're now finding that we'll give chemotherapy along with immunotherapy even before they ever go to surgery. So when's the best time to use it? We're really learning that, and we're using it more and more in different situations. Long-term side effects, primarily most of the autoimmune side effects are transient. So people will have some type of reaction where their immune system attacks their body, and generally that reverses, and therefore there are not generally long-term side effects, with the exception of being one, we see patients' thyroids develop insufficiencies, or people develop hypothyroidism. And occasionally we'll see people's pituitary glands stop working. Both of those situations are fairly easily treated by replacing the hormones that are not working any longer. A rare permanent side effect that we've seen occasionally is developing type 1 diabetes. Of course, that would be treated with insulin. But for the most part, we feel that the side effects are generally manageable, and for the most part, do not become long-term side effects. So, is this right for you? Of course, this is one of those questions you'd have to discuss with your doctor who's eligible. Pretty much anybody that would need to be treated with immunotherapy can be treated, except for people who have some very serious types of autoimmune disease. Things like multiple sclerosis, for example, is one where we get very nervous about using this type of treatment. If somebody had, for example, a kidney transplant or a liver transplant or other transplant recipients, there's a likelihood that they would lose their transplanted organ. Unfortunately, those patients are prone to get cancer because they're on immunosuppressive treatment for their transplanted organs. But those are some specific examples where we would not be able to use immunotherapy. These drugs are generally very, very expensive. right now, insurance companies cover these for the most part. In patients where the insurance company denies treatment, we have been able to get free drug.
Question on the back.
So we have been able to get free drug from the companies, and that's been very helpful because the companies generally will give us free drug for those patients who don't have insurance coverage. So as a clinical trial, right, for me, currently there are a lot of clinical trials using immunotherapy. We have a number of ongoing clinical trials where we're testing immunotherapy in situations we hadn't used it before. A good example right now, we have a couple of patients who are on a clinical trial for bladder cancer. And in bladder cancer, the standard of care has been to remove the bladder. And there's a great team up at Stanford where we send patients to have this done. However, some patients say, well, gosh, do I really need to have my bladder removed? And so currently we're looking at clinical trials where we are giving a mild form of chemotherapy along with immunotherapy and radiation therapy. And the hope is that this will prove that patients don't need to have their bladder removed, that we can remove all the cancer, get their immune systems activated so that they can avoid surgery and keep their bladder. And we're also doing this in head and neck cancer and a number of other different cancers. So yeah, as a clinical trial with me, I mean, generally we'll try to talk to our patients about that and offer a clinical trial if it seems appropriate. Yeah, a couple of things about clinical trials. Yeah, nobody's really getting a sugar pill or placebo. Usually if there's a placebo involved, it's that we're adding something to standard of care. So in a clinical trial, patients generally aren't going to get nothing. They're getting whatever the standard of care is, plus either placebo or the new treatments. And that's kind of where immunotherapy is being used. Types of immunotherapy. So some of the more common drugs we use are referred to as checkpoint inhibitors. And generally that's kind of saying that the immune system is set up so that our immune system recognizes things that shouldn't be there, whether it's a virus or a bacteria. But our immune system typically don't attack our own cells because they have molecules that tell the immune system not to destroy the cells. And so cancer cells have figured out a way to cloak themselves with, in a sense, a checkpoint that tricks the immune system into not removing the cancer cell. And so we're able to inhibit that process so that it, in a sense, removes this cloaking device from cancer cells so that our immune systems can then go in and remove the cancer. So that's what checkpoint inhibitors are. We've been using other monoclonal antibodies for a long time. That's kind of a more generalized term that just describes a way of attacking proteins on cancer cells. And so that's a very commonly used strategy that's been around for a long time. Cell therapy, cytokines, these types of things, a lot of these things are in process, or things that we're doing. The oncolytic virus therapy, for example, we use that very rarely, but that's used in melanoma. Cytokines, we used to use a lot more, things like interleukin-2 and interferon. We don't use those nearly as much anymore because the checkpoint inhibitors have been so effective. So that's kind of why I think the most of this is focusing on the checkpoint inhibitors. And again, this is just kind of reiterating the fact that our immune systems are sort of set up to not attack our cells, and that's through a system that we call checkpoints. And cancer cells have figured out how to trick the immune system into not attacking them. And so by inhibiting these checkpoint pathways, the immune system can then remove cancer cells. And this is a little diagram sort of describing that process. And this is mediated through T cells, and T cells are a type of lymphocyte. And these lymphocytes can get activated. And once the checkpoint inhibitors are used, it allows the T cell to recognize a cancer cell and remove it just like it would a bacteria or a virus. And for the most part, there are really three different categories, what we'd call PD-1 inhibitors, PD-L1 inhibitors and CTLA-4 inhibitors. There's only one drug that's in the CTLA-4 inhibitor category currently, a drug called ipilimumab, although there's a second one that's going to be FDA approved shortly that may be more effective and better tolerated. Examples of the PD-1, PD-L1 inhibitors include, and there's a whole list of things here, atezolizumab, avelumab, durvalumab, et cetera, we use all of these somewhat interchangeably, but most of these have been FDA approved for specific types of cancers. So, pretty much every cancer, we can use these, and there are certain cancers that become a little bit resistant, but most of these were initially used in melanoma, which it's very effective. Lung cancer, it's very effective, as well as a host of other cancers, including kidney cancer, et cetera. And this is kind of going through, I think, all of the different subtypes of Keytruda. You probably see them advertised on TV a lot, and they're one of the first ones that came out, and therefore they have a lot of approvals that were given by the FDA. Nivolumab or Opdivo is the second one that was approved and also has a whole host of FDA approved cancers for which it is used along with Keytruda. They are probably the two most common used checkpoint inhibitors. And atezolizumab we use in bladder cancer, lung cancer, small cell cancer, and in triple negative breast cancer. And durvalumab has kind of found its place in lung cancer, which we use for the most part after a person has received chemotherapy and radiation therapy. And cemiplimab or Libtayo is a PD-1 inhibitor that we use for the most part in cutaneous skin cancer, mostly squamous cell cancer of the skin, but it also now recently had approval in lung cancer. Ipilimumab, as I said, was one of the first ones that came out, and it's called the CTLA-4 inhibitor, and it's very effective, though arguably a little bit more toxic than the PD-1 or PD-L1 inhibitors. And we will combine these with other therapies. Currently, we use dual checkpoint inhibitor, which is nivolumab and ipilimumab, so a CTLA-4 inhibitor and a PD-1 inhibitor. That's the only combination of two immunotherapies that we use together. But there's a lot of different clinical trials that have shown benefit using chemotherapy in combination with immunotherapy drugs. And then briefly, kind of going through the whole monoclonal antibody, there's a lot of these, and so I don't think we're going to spend too much time. But monoclonal antibodies are basically synthetically made antibodies, and antibodies are part of our normal immune system, but these are synthetically made so that they specifically will attack a part of a cell, and there are certain markers on cancer cells that we can use as targets to go after, and that's how monoclonal antibody therapy works. So yeah, this is kind of going through some of the diseases, the multiple myeloma, Hodgkin's, ALL, leukemia. We use a lot of different monoclonal antibodies in these diseases. Boosting the immune response. So this is really pretty exciting, and you hear about this in the media, and it's what's called CAR T-cell therapy. And it's basically where we will take out a person's T cells, activate them in a lab, and then give them back to a patient so that in a sense they have a growing, living cancer treatment that can live in their bodies and continue to grow. And it's a fairly new therapy. There was a couple of articles in the news recently about some of the earlier patients who were treated with this maybe 10 years ago in certain diseases like leukemia, where they appear to have been cured with this. So it's a very hopeful type of treatment, though they're still trying to tease out some of the side effect issues And so currently, we've had a number of patients who are treated with this, but it's not something that's commonly done because it has to be done at a large tertiary teaching hospital such as Stanford or UCLA. And currently, when I send patients up there to get treated with CAR T cells, they often get put on a waiting list. And the waiting list is such that for some of these diseases, they'll only treat one patient per month. So it's not all that available, but it is out there. And Stanford, for example, has treated probably about 400 to 500 patients, is my understanding. But it's an exciting technology that is up and coming and continuing to evolve. And cytokines are things we used to use quite a bit, which are things like IL-2, which is interleukin, and interferon. And for the most part, that's all we used to have when we would treat some diseases such as melanoma. But we knew from the responses that we would see with cytokines that the immune system was tied to the treatment of these diseases, and that really subsequently led to the checkpoint inhibitors. So to be honest with you, we don't use a lot of cytokines anymore. And vaccines also are super exciting. They're sort of a small niche today. We do use what we call Sipuleucel T or Provenge, probably the one that we use the most. That's used in prostate cancer. There's been a lot of clinical trials looking at vaccines. They haven't panned out as well as we would have liked because there's just been a lot of negative trials. So again, the checkpoint inhibitors have really advanced to the point that people aren't looking at vaccine trials quite as much as they were in the past. We also still use BCG for bladder cancer. And again, this is an older treatment where we're instilling a bacteria into the bladder, causing inflammation in the bladder, getting the immune system to get revved up. And this was a treatment that, and BCG is similar to tuberculosis. It's like an old bacteria that we knew created a real robust T cell immunity. And so this was one of the first and earliest examples of using immunotherapy for cancer. And we still, or the urologists still do this for superficial bladder cancer. And there's really the oncolytic viruses. We usually, there's one called TVEC that we use in melanoma, but for the most part, there aren't a whole lot of these that are being used on a regular basis. And there are some clinical trials that are currently ongoing looking at oncolytic virus therapy. Side effects. And again, I think most of these were alluding to side effects that you would get from the checkpoint inhibitors. And again, the idea is that the immune system gets revved up to attack the cancer cells, but in doing so, there's crossover activity such that the immune system attacks a person's own healthy cells. And because these are T cells that are getting activated, and T cells are the cells that also fight off viruses, some of the side effects are a lot like having a viral illness. So it's not uncommon that patients would complain of having some mild fevers, chills, just feeling super tired and pretty wiped out, just like you would if you had a viral illness. Things that we get nervous about are things such as colitis. So if a patient calls us and is having diarrhea, we treat that very aggressively with steroids, which for the most part are drugs like prednisone and dexamethasone. And if needed, we put these patients in the hospital and make sure they get adequately hydrated. Other things that can be fairly serious are things like pneumonitis, which is basically inflammation of the lung. That often is that presents with a cough and some shortness of breath. And as you can imagine, it can be kind of confusing because some of these patients have lung cancer, and so they start out with the cough and shortness of breath. So it gets a little bit tricky figuring this out, but we're getting much better looking at CT scans and looking at patient symptoms and figuring out when it is pneumonitis. And when it is, then we will treat them with immunosuppressive therapies. And I always like to think of it as like we're sort of stepping on the gas pedal of the immune system to get the immune system to attack the cancer. And if the immune system gets a little bit overzealous and starts attacking the body, then we can put the brakes on with steroids or other types of immunosuppressive drugs. So I think they're just saying that you can get some delayed reactions. And so if patients are being treated with immunotherapy, we continue to watch them really for months and months afterwards, recognizing that some of the side effects can pop up late, even after months after the drug has been given. Quality of life, distress in cancer. So this is important that we recognize that there's a lot of stress and distress, as well as depression and other psychological problems that anybody would be expected to go through, going through cancer and being faced with the toxicity of the treatments, as well as the possibility of dying from the disease. And we feel that it's our job to make sure that we're checking with our patients and making sure that we're helping manage all of the things that go along with a diagnosis of cancer. Options to choose treatment, yeah, and dealing with stress. And I think also I should say that it's also important that we recognize that sometimes it's even harder on the families, the spouses, the kids, everybody in the family is part of this, of the equation. And I think it's our job to recognize that everybody in the family is dealing with this stress, which is kind of a lot like why we have some of our support groups that we can talk about if we have time. And more about dealing with stress. And again, this is also what the cancer support community does, is to make sure that outside of the limited time that sometimes the doctor has to spend with the patient and family, that we have other people that we can put patients and their families in touch with, whether it's social workers, psychologists, support groups, those types of things. And again, that's part of what Candace is here for. And again, this is, I think, really saying the cancer support community is there for patients and their families to help with this incredible stress that patients and families are put under. And again, we have lots of different ways we can get support. And if patients and their families aren't feeling supported, then that's important for them to reach out to the cancer support community. The Hearst Cancer Resource Center in Santa Maria, there's another, Marion Hospital also has a resource center. And like I said, we have set up some support groups through our surfing program called Surfing for Hope. And the future of immunotherapy, which I think is really fascinating. I'm not sure how much these slides will talk about what they're doing, but some of the most exciting stuff, like I said, CAR T-cell is super exciting. However, it's becoming just, the feasibility of doing it is limited because they're not taking and treating a whole lot of patients. And there's a next wave of technology that is more of an off-the-shelf type of treatment where the patients don't have to have their T cells removed. And some of this technology is something called BiTE therapy. I think there may be a slide on this, but basically it's where we would get the immune system, maybe not, but so it may be that you won't have to go to Stanford for us to get your T cells activated to attack the cancer cells. And this technology, for the most part, is something called the BiTE therapy, where it's basically they're going to be able to engage the T cells with the cancer cells by linking them together through the immune system. And that technology is super exciting. And there's going to be some of those new treatments that are coming online. They didn't talk too much about this either, but there's something we call antibody drug conjugate, or ADC therapy. And it's basically where a monoclonal antibody is attached to a payload, and the payload usually is a chemical that will poison the cancer cells. So the antibody brings the payload to the cancer cell. It gets engulfed into the cancer cell and then kills the cell. And they call that antibody drug conjugate therapy. And there's a number of those drugs that are in development as well. So there's super exciting therapies that are coming out there, and all of it does seem to be related to immune therapy. If you look at drug development currently, there's really no companies that are essentially developing chemotherapy. Everything now, I think, it can be listed as either a targeted therapy or an immune-based therapy. Those are really the treatments of the future of cancer care. And I think the important thing about these targeted therapies and immunotherapies are that they generally can be less toxic, number one, and number two, they're generally going to be more effective because they're very specific for targeting the cancer cell, as opposed to just toxically treating all kinds of cells in the body. And that's why the side effects of chemotherapy are so significant. So if you guys have questions, this would be a good time to open up and answer any questions that you guys might have. Can y'all hear me?
Yes, Dr. Dorian. Dorian is here. Can you hear me now?
I hear you. Yeah, Dorian.
It's Paul. But so is like Keytruda, is that a biologic? My husband who's sitting here, he's went through 2 treatments of Keytruda, and then he went into a thyroid storm, and now he's back on that. He had tried 4 different chemos before Keytruda. So we're a little concerned because he just had his first Keytruda restarted again. So
Yeah, I mean, it's definitely again, it's a monoclonal antibody that is blocking that checkpoint that is on cancer cells, and that's keeping the immune system from being able to remove the cancer cells. And I'd like to think of it as like a cloaking device. In other words, the cancer cells have this invisibility cloak that's wrapped around it, so the immune system doesn't do anything to it, and these monoclonal antibodies are specifically removing that cloaking device. So now the immune system can go in and remove the cancer cells. So the thyroid issues are a very common side effect, and generally it can be mediated through the antibodies or the immune system attacking the thyroid, but very often it's the immune system attacking the pituitary gland. And when that happens, a person's we call it TSH, or thyroid stimulating hormone, will often drop. And when the thyroid stimulating hormone drops, then the production of thyroid hormone, which we usually measure as T4 and T3, then that subsequently drops. And it's kind of confusing because usually when people develop hypothyroidism in a primary care setting, their TSH will go up because it's not usually mediated through the pituitary. So it's kind of it's a little bit of a nuance that oncologists are now well aware of, and we monitor very closely for that. Because if the pituitary gland isn't working, then there are some other downstream effects that have to be taken into account. And sometimes there are other hormonal things that will develop, like, for example, a person's adrenal gland might not be functioning, or they might not be making cortisol and things like that. The good thing about things like the thyroid problems and adrenal gland problems is we have very effective ways of dealing with that. We simply just replace the hormones that aren't being produced with synthetic hormones. So in your case, it sounds like they'd probably put you on some type of synthetic thyroid. Usually that's levothyroxine or Synthroid or something like that.
exactly.
But but that's not a side effect that we usually will stop the treatment for. Usually we'll say, okay, that's fairly common, we can deal with that. And if we believe that the benefit of the treatment is going to outweigh these types of side effects, we're going to push on and keep treating.
Yeah, it was 2 months because it turned into not only a thyroid storm, but tachycardia, heart racing issue also maybe affiliated with it too. So it was a 3-month sabbatical, and now we're back on it. I'm back on it for the first treatment, and then planning on it's continuing it. But with that same note, if the body has the thyroid has been affected, which I think now is hypothyroidism, the hyper is going away. Theoretically, it's been suggested the thyroid is now not producing, so I am on levothyroxine. But because the body reacted to that, is there a chance then that the pituitary gland or whatever, as me as an individual, by the Keytruda, is it common that it has other side effects other than the thyroid?
Yeah, so, and that is pretty common that the TSH will go up really high because it's sort of being activated, and then it drops down really low. And after something like thyroid storm, and we'd have to look at your labs to determine if it was related to the pituitary or the thyroid. So the pituitary gland is producing thyroid stimulating hormone, and that's activating the thyroid to produce thyroid hormone. So it's kind of, and it's pretty easy to figure out where the problem is, but it's not uncommon that if the pituitary gland was affected, then there's other hormones that the pituitary is producing, such as something called adrenocorticotropic hormone, or ACTH. And ACTH, if that's not being made from the pituitary, then the cortisol levels will drop, and you'd be pretty sick if that were the case. But I'm pretty sure your doctor, I'm not your doctor, I don't think, but I'm pretty sure your doctor would be checking those things also. So if somebody's having thyroid problems, then usually we're checking the ACTH, and we're also checking cortisol levels. The other hormones that are being produced are things like what we call luteinizing hormone and follicular stimulating hormone. And those, for example, could cause a drop in a man's testosterone level. And so some of my patients are on Synthroid or synthetic thyroid hormone. They're also on synthetic cortisol, which is hydrocortisone, and they're also on testosterone. So essentially we're replacing all of the hormones that the pituitary stopped making. So my guess is that your team of doctors there are checking all of those other hormones as well.
We'll follow up with that. The TSH, I know we've been doing a lot of blood checks and blood works for the thyroid. I haven't seen the other come up on the thyroid panel, but we'll look into it.
Thank you. Your
just tell them
presentation has
that.
been great.
Tell them to check an ACTH and a cortisol and probably a testosterone level too. That'll kind of give you the answers right there.
Okay, thank you.
All right, it looks like Pat has a hand up. Pat, you are muted, so if you do have a question, yeah.
Yeah, I'll put my video on too. So Dr. Spillane, thank you. I'm currently a patient down at UCLA. I'm 46 days post stem cell transplant for MDS. And so, I've been kind of interested in doing some reading on the CAR T therapy. I didn't know anything about the later generation therapies that you spoke of. But so I understand that every once in a while, there could be a recurrence of the one or more of the cancer mutations. And so I was kind of trying to understand what the path forward would be. And so what do you see in that situation, say like 2 or 5 years down the road, and I would be in my mid-70s?
Yeah, I mean, so myelodysplastic syndrome, that's a difficult disease, as I'm sure you know. And it's unfortunately, a whole host of different types of mutations that lead to a stem cell in the bone marrow just kind of, failing. And so can you develop, in other words, a system where you get antibodies to attack a specific type of cancer? And they're not quite there yet. In other words, like, could they take out So right now, all the CAR T cell, they're using common antigens or common proteins on cancer cells. So in a lot of these, for example, there are certain proteins on multiple myeloma cells, and there are certain proteins on lymphoma and leukemia cells. So they already know what the protein is that they're going to activate your T cells against. Myelodysplastic syndrome becomes a lot more difficult because it's not just one protein in the general population. There are a whole bunch of different mutations, and myelodysplastic syndrome often is a whole bunch of different types of diseases. Having said that, though, you're right. There's the potential future where, in theory, everybody's cancer, depending, no matter how unique it is, you could develop a technology where the T cells become activated against that particular cell. So, I mean, I guess I would sort of say, yeah, over the next 4 to 5 years, it wouldn't surprise me that we would have technology that would even be specific enough to use immunotherapy in more difficult situations like this myelodysplastic syndrome. So you had a donor stem cell, or you had your own autologous stem cells? Is that
No, it was allogeneic.
Allogeneic.
Yeah, and we went out
Yeah.
to the registry.
So, I mean, so what they're doing there, which is fascinating too, is basically giving you the immune system of somebody else, and that somebody else's immune system recognizes that it should get rid of all of your bad stem cells. And so you basically develop an immune system of the donor, and that's why it works. Which kind of bypasses all of the specifics of these CAR T cell and other types of immunotherapies.
Okay.
You're doing okay though. You look good.
I'm doing really well. So
That's fantastic. Yeah. So that's, one of the questions though, like if you have have an allogenic donor, and this has come up every once in a while, what if you then developed a disease that we would commonly treat with one of these checkpoint inhibitors? And the question is, would we trigger your body to then lose, lose the graft, because essentially you have a grafted bone marrow, and that situation gets a little bit tough, and it just would depend on what the disease was and what the immunotherapy was being used for.
I see.
But nonetheless, you seem like you're in a pretty good situation now, having gotten through. How long ago was your stem cell transplant?
46 days. It was January
good. All right.
21st.
So you're still on immunosuppressive agents at this point, right?
Absolutely. Yeah.
Cellcept and all the other different things, right? Yeah. All right. Well, very good. Thanks for telling me that story. It's a great story, though.
I appreciate it. Thank you.
I see a question from Pat's iPad.
I think that was just
That was me. You
yeah.
already.
Okay. Any other questions? All right. So I guess if there are no more questions, we can go ahead and wrap up. I will make this, for those of you who are interested in actually getting a copy of this presentation and the slides, if you would like that, if that is helpful for you, please let me know. I'm happy to go ahead and email that. I also did record this presentation, so I'm happy to send you the recording as well. And as I mentioned, there is a survey. Here, I'll stop to share. There is a survey that would be really helpful if you could complete that for us. The link is in the chat box, or I can email that to you if that is helpful. I'll go ahead. I'm going to put my email in the chat box as well. So if you do want for me to send you the slides as well as a copy of the presentation, I can do that. So just go ahead and send me an email and I'll make sure you guys get that. I guess with that, I'll let everybody kind of get ready and enjoy your evening. Maybe go grab some dinner if you haven't already. There's anything else?
I'd like to thank you guys both for a great presentation. Thank you for letting us sit in on that, and they're very informative.
Wonderful. Well, thank you so much for joining us. Like Dr. Spillane said, here at Cancer Support Community, we are here for you. So if there's anything you need, please reach out to us, because, if we can't help you, we will find the resources and find somebody that can. All right. Well, thank you, everybody. Have a good evening. And thank you, Dr. Spillane. We really appreciate it. And we will see you soon.
Thanks, Candace.
All right. Thanks, guys. Have a good evening.